Just a quick word about Gynuity Health Project. It is a nonprofit organization based in New York. We have some offices in Georgia, in Mexico, in Senegal, and we predominantly work in medical abortion, but also in postpartum hemorrhage, preeclampsia, and other reproductive health service questions. We conduct research. We do some advocacy work using research. We also provide technical assistance to NGOs and government members in revision of guidelines. So I tried to pick some topics for this presentation that are applicable to this region and to the context of medical abortion in Eastern Europe and Central Asia. So I'll be talking about bridging the gap between 9 and 13 weeks of gestation, looking at mifepristone and a limited dosing of misoprostol in second trimester medical abortion, an outpatient model of second trimester medical abortion, and also provision of care of the first trimester using telemedicine. So I think all of you here are experts in medical abortion, and all of you know very well that medical abortion is very safe and extremely effective, up to 63 days of LMP. But there is now a lot of research that supports outpatient medical abortion in the 10th week. And in fact, in the United States, medical abortion, outpatient medical abortion or abortion at home is a standard in the United States, but also in some of the countries in the region, including the Republic of Georgia. So I think it's very important to think of abortion efficacy among the continuum of gestational age, and not just think that when somebody is, let's say, 71 days LMP, all of a sudden she has to go into the hospital and have the service in the hospital. So our research in this region includes provision of medical abortion up to 70 days. So we had performed 2 studies, one in Western Ukraine and one in Kazakhstan, where women in Western Ukraine took 200 milligrams mifepristone at home or in the clinic. They had the option. And then 24 to 48 hours later, they took 800 microgram buccal misoprostol at home. So we chose the 800 microgram buccal regimen for this specific studies because the providers in that country did not have experience going up to 70 days, and they wanted to have more experience using 800 buccal misoprostol. In Kazakhstan, we used 200 milligrams of mifepristone. The women were able to take it at home or in the clinic. And 24, 48 hours later, they took 600 micrograms sublingual misoprostol. So in case you're wondering why is this 600 micrograms of misoprostol, is that at the time of that study, the packaging was available with 3 pills. So we didn't want to explain to the women, okay, take 2 pills, but throw the 3rd one away, or have to explain to them, or have to cut the packaging so that the providers would only give 2 pills to the women. So we used this standard packaging that was available. Since the study had concluded, actually they had repackaged their misoprostol, and now you can buy a package of 4 pills or 800 micrograms of misoprostol. So some of the results here, because of interest of time, I'll only focus on some of the key outcomes. One thing I wanted to note is that these studies were not designed to look at the efficacy by week, but I did want to highlight the efficacy of the method in the 10th week, which is 64 to 70 days. I know the numbers are quite low, but this is, once again, we had a sample that the providers were enrolling, and we weren't focusing on week-by-week efficacy. But as you'll notice in Kazakhstan, the efficacy was, in the 10th week of pregnancy, was 94%. And if you compare that to 9th week of pregnancy, the numbers are very similar. In Western Ukraine, the method worked really, really well all through the 10 weeks of pregnancy, and in fact we had able to reach 100% successful abortion rate in that study. So moving beyond 70 days, we've done a few studies looking at the efficacy of medical abortion in the 11th week in this region. I believe Armenia was part of these of the study. So one study, which was a multi-site study, looked at a regimen of 200 milligrams of mifepristone, 24 to 48 hours later, followed by 800 microgram buccal misoprostol. And once again, we use buccal misoprostol because this is the standard regimen used in the United States up to 10 weeks. The second study was a retrospective chart review, which looked at use of mifepristone, 200 milligrams of mifepristone, followed 24, 48 hours later with 800 microgram buccal misoprostol, with a repeat dose of buccal misoprostol 4 hours later. So if you look at the results, study one, this is the study that used one dose of buccal misoprostol. The medical abortion was quite successful, both in 10th and 11th weeks. In 10th week, I don't think there's a pointer, but in the 10th week, for study one, success rate was 92%, and it did fall a little bit in the 11th week using the one dose of misoprostol. What's interesting is that for study two, the retrospective chart review, where the woman took a second dose of misoprostol, the efficacy rate was quite high. In the 10th week, it was 97%, or almost 97%, and in the 11th week, it was 98% successful. So I think this study suggests that possibly a second dose of misoprostol would be beneficial in the 11th week of pregnancy. So I'll now switch to second trimester medical abortion. Most of kind of go-to global guidances recommend 200 milligrams of mifepristone followed by repeat doses of misoprostol. And one example I'll bring is the WHO recommendation, which recommends going up to 5 doses of repeat misoprostol. But there are no kind of instructions on what to do next. Some countries have a resting period where they continue the misoprostol administration the following day. In other countries, and this is very common in this region, is that after the 5th dose of misoprostol, the doctor performs a curettage. FIGO, though, is recommending 200 milligrams of mifepristone followed by repeat doses of misoprostol until the expulsion of products of conception. So we did study this question, can you go beyond 5 doses of misoprostol? And we conducted a study in Ukraine and Uzbekistan where women were able to take 200 milligrams mifepristone at home or at the hospital. So some women came in, they had their consultation, they were able to take the mifepristone home and start their induction with mifepristone at home. And then 24 to 48 hours later, those women came back and started induction with misoprostol using 400 micrograms sublingual misoprostol with repeat dosing until complete expulsion of products of conception. So in terms of the results, 97% of women who participated in the study had a successful abortion. And as you notice, by 15 hours, so this is basically the last, kind of after the last 5th dose of misoprostol, almost 87% of women had expelled. But you'll notice that there were a few women who needed additional doses of misoprostol and continued to take misoprostol until the expulsion. And on average, we found that women needed about 3 doses of misoprostol. But if you look at the range, it went as high up as 11 doses. And about 10% of the women required more than 5 doses of misoprostol. The other curious thing that we noticed is that about 30% of women completely avoided having to stay in the hospital overnight. So this includes women who were able to take mifepristone. They went home, they came back for misoprostol induction. They took whatever number of pills they needed in order to expel the process of conception, and then they were released from the hospital to go home same day. You'll notice that in Uzbekistan, it was almost close to 50% of the women who did not have to stay in the hospital overnight at all. The reason for this is because in this study, there were more women in the earlier gestational age category, so 13 to 18 weeks, rather than the later gestational age category, which was 19 to 22 weeks. So given this information, along with some other data that we have from other studies at Gynuity Health Projects, we actually are now testing this new model where the women take mifepristone at home, and this is a new model for second trimester medical abortion. The women take mifepristone at home, and they also take the first dose of misoprostol at home or in transit to the hospital. Then they continue their misoprostol induction until the expulsion. If the women require more time at the hospital in order to have complete expulsion, then they're now transferred into an inpatient facility. So the study is ongoing right now in Nepal, and hopefully we'll have more results coming out very soon. So switching a little bit back to first trimester medical abortion, we're also testing a new model where the women communicate with the provider completely via a computer or a phone. So she obtains her pre-abortion testing at a local laboratory, or they go to an ultrasound facility where they can receive their ultrasound results. The results are then sent to the provider who is at the clinic. They review the results, and she's eligible for medical abortion. She has a video evaluation using something as simple as Skype. The provider then counsels the woman, packages the mifepristone misoprostol, mails it to the woman. She receives it at home. She takes the medication, and then 7 to 14 days later, she goes back to the local laboratory or the ultrasound facility to have her follow-up results done there, and those results are then sent to the provider. We have enrolled about 160 women in the study, and we're hoping to have more information available for you as that becomes available as well. Oh, sorry, I meant to say that this is happening in 5 sites in the United States. So a couple of key messages. Outpatient medical abortion up to 12 weeks of gestation is feasible, safe, and effective. Providers may provide continuous misoprostol past 5 doses in the second trimester medical abortion. Outpatient models of care can expand access to services while maintaining high quality, and technology can enable providers reach women who may be very far away or unable to access a medical center. And then just in conclusion, I just wanted to say, in terms of where do you see guidance or medical abortion, there are drug companies that provide an insert that comes with the packaging that you can find information there. There are global medical abortion guidelines like the WHO. Professional associations, for example, in the United States, we have a National Abortion Federation, which also issues guidance to its members. And lastly, there are national medical abortion guidelines that are issued in each country. So, for example, like the clinical protocol in Ukraine. But I think it's really important to think about the context in the country and what are the needs of those women. So while the WHO, for example, may give you some very helpful guidelines, they also use very strict criteria in determining their recommendation, but they don't necessarily may include clinical experience of certain studies that may not be a randomized clinical trial. And to paraphrase my boss, Beverly Winnikoff, the president of Gynuity Health Projects, we know that parachutes are very effective, right? But do we really need to have a randomized clinical trial to show that they're effective? No. So I highly encourage everybody to really look holistically and look at all the information out there, all the evidence out there when putting together guidelines for providers of medical abortion. So thank you.